Hey guys, my name is Mavi and I've spent the last 14 years in the plastic surgery and beauty industry, working alongside top board certified plastic surgeons.
Now I'm an independent patient coordinator who doesn't work for any surgeon. This means I have unbiased reviews for hundreds of doctors and I can help you achieve the look of your dreams, whether that's a supernatural or a video vixen. I use my professional and personal plastic surgery experience to help you look and feel your best.
Join in on the fun as I talk to plastic surgery experts, friends, and real-life patients about all things plastic surgery. Should be fun.
Hey guys, do I have the episode for you today? Today I have Dr. Daniel Gould, a board-certified plastic surgeon from Beverly Hills. We are going to talk about all things beauty. I'm trying a different format, so I hope you guys like it. We're actually recording video to go with this episode, so you'll find that on YouTube, on the Big Butts No Lies YouTube channel. Hey guys, so I have Dr. Daniel Gould with me here today. And Dr. Gould, why don't you introduce yourself to us?
My name is Dan Gould. I'm a plastic surgeon board certified by the American Board of Plastic Surgery in Beverly Hills, Los Angeles, California. And I've been in practice for several years in that location. Some of the things that I'm passionate about that I enjoy doing in my practice include deep plane facelift, drainless tummy tuck, and complex breast surgery. But I do plastic surgery from the head to the toes. I've been trained in the top aesthetic surgery fellowship in the United States, and I did my residency at USC. And something that differentiates me from other doctors in plastic surgery is I actually have a PhD. So I did a whole background training in tissue engineering and bioengineering. And I've utilized some of my interests in science to help make plastic surgery better, not just for my patients, but also for patients throughout the globe by publishing a lot of articles and giving a lot of abstracts and talks. And in fact, even though I don't have a lot of gray hair, I've published almost 170 peer-reviewed publications and done over 800 talks at national meetings and international meetings, and many more abstracts, which differentiates me from most surgeons at the age of 40 in their career by a long distance. So some of what I do is looking at the science behind what we do in plastic surgery and actually doing studies in my own outcomes to help improve the quality of care for patients by changing what I'm doing in the perioperative management and improving what we can do for patients to make the experience better. So those are some of my interests and some of my kind of background. Some of the other kind of important accolades. I'm an editor for the Aesthetic Surgery Journal. I'm a contributing editor. And that's very important because I also help to vet the science that goes into the quality of outcomes and the research that occurs in kind of our space in plastic surgery. And I serve on several different boards for aesthetic research, education, and for the Aesthetic Society, which I'm a member of. So those are some of the basics. My kind of hobbies and other personal time include just working out and doing other things kind of in Los Angeles that I'm kind of passionate about. But I have to be honest with you, most of my time is spent on my practice because I'm very passionate about it. And it is definitely my obsession at this point. Those are the basics. I'm happy to get into it and talk to you about some of the things that I do.
Yeah, that's awesome. So let me tell my girls, y'all can already hear why he's on the show. My girls know I love to bring on experts that can really showcase and highlight specific procedures and how to stay safe and how to better their recovery. So any tips that you can give us during our conversation are going to be so appreciated by all of our listeners. So before we started talking, you guys, I was talking to Dr. Gould about me being team drains. Y'all know, if you know the show, you know I'm team drains. And Dr. Gould said, well, let's see if maybe we can turn you team drainless. And I would love to see it because you guys love those drainless tummy tucks. And I'm so happy to have an expert on. So let's talk about it. Tell us the difference, between having the drain in, not having the drain in, who can go drainless and who has to have a drain. Those are really important questions for our girls. So please tell us.
Well, so it's interesting because it's not that I'm against drains in general. And this sounds very strange, but for high def lipo cases and intense lipo cases, I almost always use a drain. So it's weird because my liposuction patients, I've got a drain in, and my tummy tuck patients, I don't. Okay. So in most cases, in fact, I cannot remember the last time I used a drain in a tummy tuck, but I use drains in every case for lower face and neck lift. Okay. So it's not that I'm against the use of that small tube. And I think that in some of those cases, the main reason I'm using the drain is to get the skin to stick down to actually show you better definition. So in high def, I don't have stitches on the inside to pull the skin down to the fascia. So I use the negative pressure, the suction from the drain, to help better define what we're seeing. In the lower face and neck lift, I'm using that drain to get the skin to stick down to the platysma to maximize the amount of adherence here. But sometimes I also use stitches from the outside in, like that Spidey facelift that you've seen, in order to improve the contour and the retention of the skin to what's below. Now, in drainless tummy tuck surgery, the question was really asked, and this was back in the 1990s. Okay, so this is almost 30 years ago. Two father and son teams in Dallas, Texas, figured out a way to do the surgery without drains. Antonetti and Antonetti and Pollock and Pollock. Okay, so father-son plastic surgery teams that were duking it out in the same turf, trying to improve the quality of care for patients. And what did they discover? They discovered that if they utilized sutures on the inside, they could progressively add tension to better define the quality of the results of the abdominoplasty. And when they did that, it got rid of the space where fluid could accumulate. Now, seroma is the main complication that we're trying to avoid by using drains. And seroma is formed by empty space. So if you have the fascia here and the skin here, and you pull it down and you just close skin without closing the space between the two, then you've got this open space between the two that fluid can accumulate within. And anywhere in the body where there's open space, you may have fluid accumulation. So we get rid of that space by using the stitches on the inside. So we've pulled the skin down, and at each point as we're pulling it down, we're putting a stitch, putting a stitch, putting a stitch. Turn to the side. These areas are all adhered to each other. There's no space where fluid can accumulate. So what does that mean? That means that the risk of seroma is lower. How do we know that? There have been multiple scientific studies where we've looked at patients. In my practice, I've written over 7 scientific articles on this, which are peer reviewed. That means other surgeons that don't like me looked at my data and said, yes, this is actually true. Okay. I did one study with 451 patients. That's almost 13 years old. Another study with 619 patients. Okay. That's more like 7 to 8 years old. You can Google all of this information, look up Gould and abdominoplasty. You'll find at least 8 articles on the subject. But in these 2 articles, what did we do? We looked at patients that had the surgery without drains. And in one article, we looked at sort of patients with drains and without. So we looked at the transition of our practice from using drains to not using drains. And what was it that we found? Well, in the literature, if you add up in all cases, the risk of seroma in patients where surgeons use a drain, that risk is 9%. Okay. That's 1 in 10 patients. That's a pretty high percentage. Now, what's the treatment for a seroma? It's straightforward. You take a needle, you put it in, you suck out the fluids. It's not that complicated, but 1 in 10 patients. Now, what is that risk if you do a drainless approach? It's 2%. It's actually 5 times less because we're treating the etiology. We're treating the cause of the fluid accumulation. We're not just putting in a drain and saying, hey, well, if it happens, we'll take care of it, right? So in the drainless approach, in the published literature that's in the science these days, that risk is actually slightly lower. So we did a big study where we did what's called a retrospective review and meta-analysis, where we looked at all the systematic papers that are out there. And the combined rate of seroma for drainless approach is less than 2%, whereas traditional approach is 9%. So what's safer? If you want to ask somebody, they say, well, safety is not really like, and if you tell anybody who has a drain, who uses a drain in their approach, well, it's safer to not use a drain. They say, oh, safety is a loaded word, that use all this language. They're biased because they don't want to hurt a patient, right? Nobody wants to hurt a patient, but they want to justify what they're doing because they're afraid to create a higher risk of seroma, which I totally understand. Nobody wants to hurt patients. Nobody wants to create a risk that's higher. The worst thing in our world in plastic surgery is not a bad complication. It's an uncomfortable one or one that makes the patient complain to you. So surgeons are afraid of complaints. They're afraid of patients saying, now I have a seroma, it's all your fault, you had to take care of it, et cetera. So a lot of surgeons justify their thought process and say, I'm still going to put in a drain. But if you listen to all the people that are haters that have been talking about how much they hate drainless approaches, many of them are still copying what we're doing on the inside. So they've still used and appropriated the use of progressive tension sutures and internal sutures because it looks better. No one can debate that. Internal sutures do improve the quality of what we see. Why? Because think about it. If I can stretch the skin, if I can pull it down, put a stitch, pull it down, put a stitch, pull it down, put a stitch, then at the bottom, when there's the 2 edges coming together, I can remove the excess skin and there's no tension pulling apart. Tension is what creates a bad scar. Tension is what creates a thick, upraised, or wide scar. No surgeon will argue with me on that because that is a basic understanding in plastic surgery. So if we can take the tension off, that is a better option. So progressive tension sutures, stitches on the inside, there should be no debate on that. And any surgeon who's not doing that is behind the times in terms of the quality of the look of the result. And I think that we can all agree on that. And if not, they show me an excellent result. Say, I didn't use stitches. I say, great. You have other approaches, liposuction, high-def lipo, that you're using at the same time. As long as it looks good, we're good, because that's the whole point of aesthetic surgery. Make it look better. I think it looks the most natural when you recreate the natural connections between the skin and what's deeper. Those connections were there before surgery. So why not reestablish those? That's my mindset in every surgery I do. How do I create natural anatomy? How do I recreate the natural connections between what's deep and what's superficial? I do that in my deep plane facelift. And in fact, I've been asked to give a talk at this meeting in a week or two where I connect the dots and say, these are concepts from deep plane facelift that I use in drainless tummy tuck. And it's why it makes sense and restores natural beauty. The two are intricately related. So we've already decided that, hey, a lot of surgeons are out there, they say, I still want to use a drain, but they're still using the approaches that I've helped develop to create the internal definition, and approaches that were around way before I was even in this field. Okay, so the 1990s is when these two teams started creating this. And it was small at first, and there were only a handful of surgeons that were doing it. And just by luck, someone who trained with them trained with somebody who trained me. Okay, so it's not like I, magically created this on my own, but I have innovated in the last 6 or 7 years, and I've really done all the real research to help prove that this is an appropriate and I think reasonable way to do abdominoplasty. Now, despite all that, there are plenty of people that say, well, do what you do and just throw a drain in. It's not a big deal. And I would say, okay, let's think about that. Sure, it's safer. Let's say it's safer to have a drain because why? Because it's going to reduce the risk of your seroma, even if you reduce it from 9% to 2%. Well, is there any data that shows that drains reduce the risk of seroma? No, there have been multiple scientific studies that show if you put a drain into an animal without doing surgery, it creates fluid, about 30 cc's a day. But that's why we remove drains when it's less than 30 cc's a day. Why? Because a drain is a foreign body. It's a material that goes in your body that creates an inflammatory response. So are there risks of drains? Not really. I mean, there's local surgical site infection, things like that. If you have an implant in your breast and a drain, that might be a real risk of creating an infection around the implant. But really, there's not a big downside, but they are uncomfortable and painful. So in the world of biostatistics, what we think about is what's the number needed to treat to prevent a problem? Number needed to treat is how surgeons and doctors determine whether or not to do something, an intervention that could potentially improve the quality. If they think about how many patients do I need to treat to make the situation better. So if 2% risk of seroma with drainless tuck, that means 98 out of 100 patients have to have a drain in an uncomfortable situation to prevent me putting a needle in 2 patients to suck out a seroma fluid. Now, if it's 9%, then that means 9 patients have to have a drain for 1 patient to have suction out of fluid. So I would argue if your risk is 2%, it makes even less sense to put a drain in because I need to have 98 patients having, or let's say 50 patients having a not so great experience for 1 patient to avoid needing a secondary suction instrument or to remove fluid. Now, full disclosure, I have had seromas, 2 in the last 3 years. And I'm talking hundreds of tummy tucks. If you look at my page, you can understand I do a lot of those. And I wrote a paper where I did 3 months where I was doing a pain study and looked at 90 patients. So I was doing about 30 patients a month. Okay, that's a lot of tummy tucks. It's more than most surgeons. And I would tell you, 2 ain't bad in 3 years. Now, there's other things that I've done, and my other issues or other bad outcomes, other complications are extremely low because I've focused intensively on perioperative management. So I would argue drainless tummy tuck done where you put in a drain at the end is kind of foolish because you're not really achieving the goal, which is to avoid that, downtime and that extra discomfort that patients have. And reasonably, you can do it. And I think that all surgeons are thinking what's best for my patient. So if you're a patient and you're going to your doctor and they're saying, yeah, I do similar things in drainless, but I still leave a drain, that's fine. If you go to your doctor and say, I don't like drainless tucks, I think they're unsafe, I think they're dumb. They haven't read anything in the literature in the last 10 to 15 years. And that should give you pause because that's not a great response. That just means, I don't know, I've never done it before. I don't want to change what I do. That's fine. Just say that. Just be honest with your patients. Be transparent. I don't know how to do it. Just say that instead of trying to retain the patient and keep them in your practice even though you don't know how to do it. That's dumb. That's like when someone goes to a surgeon nowadays and they say, do you do a deep plane facelift? And the surgeon does not do a deep plane facelift, but they say, yeah, oh, I do a deep plane facelift. For 4 years, they were arguing that it was just a marketing term because they didn't understand how to do the surgery. So even at the big meetings, there were all these big national meetings of plastic surgeons, which I was a part of, where people were talking bad about the concept, just like preservation rhinoplasty. For 5 years, I watched people get on stage at the rhinoplasty meetings, talk about this very well-developed concept, and then just get completely destroyed by the other surgeons because the other surgeons don't do it. And they're afraid that it's going to change their practice. They're not going to be able to provide the state-of-the-art technology. And now I'm watching those same surgeons who are bad-mouthing this really innovative, young, thoughtful surgeon who I saw come up from being a resident, who created almost the entire specialty of preservation rhinoplasty in the United States. It's down in, we know who I'm talking about, down there in Southern California. I watched him go up on stage and get bad-mouthed about what he was doing. And now those same guys who are bad-mouthing him are putting him up, elevating him, putting him on a pedestal. He hasn't forgotten all that, right? So you have to remember that plastic surgery is a competitive specialty. People are always looking for some kind of leg up. Now, some people would argue that advertising a drainless tuck is a marketing gimmick. And I would say that in some cases it may be. If they're not using stitches on the inside, if they're just saying, I'm not going to put a drain in, that's not smart, that's not safe, and that shouldn't be done. But I would say that in most cases, it shows that the surgeon's a little bit more innovative. They've been trained in an environment where they're doing these things and they're thoughtful about it. I know plenty of young surgeons that are my age that are now instituting this and that are changing things. And I was influeed by my own mentors, by the own people around me that were doing these things and being innovative. So I would just say, if you're in a consult with a surgeon in any case, and they're bad-mouthing another technique or another surgeon, that's a red flag. That shows you a personality that is not consistent with open thought and discussion, somebody who doesn't know how to deal with confrontation, and somebody who doesn't know how to deal with real complications. Because if they did, they would understand things happen, complications occur, no matter what technique you use. And they would be very honest with you and say, look, I don't do drainless because I was trained this other way, but do you like the results? Do they look good? If they're good, you like the way they look, then maybe this is the right surgeon for you. Maybe I'm the right person for you. And then as a patient, you have to kind of think, what do I want? Do I want a surgeon who's going to be honest and thoughtful in their approach, even if they don't do a drainless, right? Or do I want somebody who, when I bring up a question about something, because I'm a little more inquisitive or because I'm a little more educated than most patients, are they going to get defensive? Like if I say, hey, why does my belly button look weird after surgery? They're like, well, I'm an expert in belly buttons. I created the first belly button back in the dawn of ages before man was born. Or are they going to say, I use this approach that's not perfect for everyone, but it usually looks great, but maybe I need to do a revision. So let's just schedule that small appointment. Let's do it in the office, no surgeon fee, whatever. So that's what you have to think about, right? Because it's your body, but once you have surgery with that surgeon, they're your surgeon for life. You're going to be going back to them. You're going to be asking for issues. There might be complications. And I think that when something comes up, surgeon has to know how to discuss. For instance, I have a patient recently, she's 3 years post tummy tuck. She came in, she said, my stomach was flat and now it's not anymore. Did the diastasis recti repair fail? So what's your current body weight? It's 180 pounds. What was it at surgery? 140 pounds. Okay. So your body has changed, right? You've gained about 40 pounds. How do you have that conversation with the patient? Are you going to say, well, you're the one who screwed up your repair. You gained weight. No. What I say is, look, there's fat on the inside, fat on the outside. What do we do during surgery? We remove outside fat. Also, we repair the muscles on the inside. How does that change with weight gain and weight loss? Well, you've gained weight. It's going to change what's going on the inside in a big way. What other ways has your health changed? Why are we at this point? And how can we get you back to a point where you're healthy again? Do I need to refer you to a doctor to talk to you about weight loss? How do we deal with those things? And then can you have a secondary tummy tuck revision? Certainly. If you get down to 140 again, you get back down to the range we're in around surgery, we can talk about doing another procedure to give you that great result back. And it may be different, maybe changed, may not be the same procedure. In this case, this woman had had 7 C-sections and had a midline laparotomy before. So she was super happy that I had restored her abdominal competence at one point and got rid of all the scars on the outside. So she already looks better, even though she's like bigger now. She was saying, I'm still happy with everything you did, but she wants to have that flat tummy back. So I told her, here's how we're going to get there. I didn't get defensive. I didn't tell her, I didn't tell her, oh, nothing's screwed up. It's not my fault. I just said, I understand what you want. Let's talk about how to get there. So drainless tummy tuck is a procedure or an intervention that is relatively new, but has not been around for only a few years. It's been around for at least 30 years. I think that in plastic surgery, we have to ask ourselves as surgeons, do I want to perform the surgery of 2023 or do I want to perform the surgery of 1970? And I think that a lot of surgeons want to perform the surgery of 1970 because that's what they were trained on. They've been in practice for 10 to 20 years. And cosmetic plastic surgery is not an academic pursuit. Most of it is a business pursuit and a financial pursuit. And so most surgeons are not the ones that are out there. 70% of the surgeons doing cosmetic surgery are not going to meetings. They're not reading the papers. They're building their business. They're doing great surgery. They're servicing the community, but they're not kind of thinking at that next level. And if that's what you want, that's fine. If you want somebody who's done 10,000 drain abdominoplasties with relatively great results and low risks of bad outcomes, that's for you. If you want somebody who can do it a little bit differently, goes to the meetings, gives the talks, advances the science, and may be able to give you a slightly better looking or a less pain or less kind of interventional issues result, then that's me. Okay. That's somebody like me who's going and helping to develop those things. Not to say you can't have both, but I think that, sometimes you have to look at it as a patient and say, okay, what is this? What is the deal with this drainless thing? What does it mean? Now, the last thing I would say is just as a reminder, what are those stitches on the inside doing? Why is this approach different? We're recreating natural shapes. In my practice, I seek to recreate the line down the middle and the lines down the sides. And I've shown that on my Instagram. I've shown plenty of patients who have carved out contours without liposuction. There's no high def lipo going on in the middle in my patients. It's all about the flanks. I change the body shape, but I don't liposuction intensively anteriorly because of the risk of bad outcomes, skin necrosis, other issues in the closure. So the first thing is that those stitches recreate those natural hills and valleys, the shadows that you see, because tummies aren't flat. Tummies have natural shapes. And restoring those, identifying those, and talking to the patient about those is how you get a tummy after surgery that looks insane. Looks like, how did this happen? Like this person who's a BMI of 35 has a six pack. How did you do that, Dr. Gould? Which I've done that before. Okay, that's how. Now, the second thing those stitches do is they get rid of that space where fluid could accumulate, so we don't have to put the drains. And the third thing they do is what I said, takes the tension off, pull skin down, put a stitch, pull it down, put a stitch, pull it down, and put a stitch. Now, I'm giving talks nowadays about how that dynamic tension, so it's not just pulling the skin down and putting a stitch, it's bringing the skin in at the same time to reach it over the ribs to get better rib show, and then stretching the skin in a way that goes like this. So then in weight loss patients, I can avoid a central incision, avoid a fleur-de-lis. So how do I adjust my approach, adjust the vectors of tension to recreate natural shapes and to add tension across that skin to give it the most tightness from xiphoid process to the mons pubis? So again, those stitches, you create that tension and create the best possible incisional closure, but also allow my patients to stand up and walk upright. So that's it. Now, why am I doing all this stuff, right? I think that you got to ask yourself, why is Dr. Gould doing all this crazy stuff? Because I look at the experience and I say, what would I want for my sisters or my mom? Like, what's the most advanced approach? And how do we get patients back to doing things they want to do quicker? 70% of my patients fly in from outside of California. They want to fly back at 7 to 10 days after a tummy tuck. They all do. Okay. Because I'm reducing the pain that happens at surgery. I'm getting rid of the drains to avoid kind of that secondary issue that they have, allow them to stand upright and walk. There's videos of them on my Instagram, my TikTok, standing up and touching their toes, like on post-op day 5, because it's different. Okay. Because I'm really approaching this differently. Now, we should talk about what I do with pain, because there's a lot of misconception about that too, and some controversy.
And I think we should totally talk about that. The perioperative, your approach in perioperative.
I, spent a couple years, probably 5 to 7 years, trying to adjust what I was doing with regards to pain control to really improve the quality of the experience, because I think that the number one fear is pain. It says, this is not your mother's tummy tuck. Everyone's heard their mom say, I had it. It was the worst thing in the world. I would never do it again, but have a flat stomach, right? Or their friends say same thing. And that's because it's a big surgery. So what are the modern concepts of pain? Now, before I dive down how we prevent pain during surgery, I have said on my social media that this is which I've marketed as painless, drainless tummy tuck. And this is supposed to be a dad joke or play on words, because I do a lot of dad jokes on my thing. There's no such thing as painless surgery. There's always going to be pain with any surgery you do. But the goal is to be like less pain, like pain less, but there is really no drain, or less drains, because sometimes people are putting in one drain. But I think I might change the marketing to say less pain, no drain, LPND, which I think is more accurate.
I like that.
Because I've been getting some feedback on that. But I'm actually not making a medical claim. I'm actually quoting the paper that I wrote. So I wrote a paper for the Aesthetic Surgery Journal called Painless Drainless Abdominoplasty, and they published it. Okay, so this is a scientifically vetted article which I could not believe they published it when they did with that title, because I thought they would say something like, don't say pain less. But in the article, I discussed pain and I said, no surgery is painless, but this is what we're talking about, less pain, right? So in that article, I looked at 90 patients, okay, over the course of 3 months. And on average, the pain score of 95% of those patients was 0 to 2 out of 10, which is unbelievable. What I'm saying to you is not believable right now, unless you go and you watch the Instagram, you watch the TikTok, you see the women the night of, the next day, 1 week out, all saying the same thing. It's less pain. I didn't think it was going to be this way. They're all saying that. They're saying, I didn't believe you, right? Some say they believe me because they're like, no, I saw all the videos of the other women. But how do we achieve that? How do we achieve a better outcome in terms of pain for patients? That's the question that every patient wants to know. So there's different approaches, but this is what I did in my practice over the course of 7 years. I kind of fine-tuned things. And what do I do now? Well, I utilize first medications that are given to the patient before surgery, okay, that are anti-inflammatory medications, gabapentin, Tylenol, and Celebrex. But I also give something called Amend, which is a brand new anti-nausea medication. And my average rate of nausea, I've had like one nauseous patient in 2 years because of the use of these medications. So I'm trying to improve the pain, but also every other aspect of the surgery. So those 3 medications are given beforehand, actually as an oral medication. So they're given as a small pill before the patient goes back. Once we're in the operating room, patient goes to sleep. So I'm in the operating room with the patient as they're going to sleep, because I want to be there to make sure that it's safe in case something happens while they're getting intubated. Takeoff and landing are the most scary times of any, plane flight. Same thing with surgery. So once they're asleep, the very first thing I do is I inject their body with a numbing medication, a specially formulated medication that I use, which I've talked about on my Instagram, which combines 6 different medicines. Okay. One of them is a short acting form of medication for numbing. The other is a longer acting medication for numbing. Then there's a medication that's an anti-inflammatory medication, one that prevents bruising and swelling, and another medication that is actually a vitamin that helps to reduce neuropathic pain later on. So I inject a few different medications, then there's 1 or 2 other meds in there. And these medications are all designed to make it so that the body is totally numb before I make an incision. Okay, now this is critical, because in anesthesia, they have this theory called gating theory, which says if you never open the gates to pain, the patient's body doesn't feel pain while they're asleep, you won't have pain later on. And this is well established in the anesthesia literature. Listen to what I'm saying. Anesthesia is not analgesia. Anesthesia is being asleep. Analgesia is feeling pain, okay, the sensation. So in medical school, they teach this when we are young bucks in medicine, but somewhere along the line in surgery, surgeons forget it. And I many times as a resident saw surgeons, after the patient's asleep, cut the skin without injecting it with lidocaine. Okay, so they make the cut. It's a big surgery. They're not going to feel it anyways, whatever. With tummy tuck, almost always they would do it. And I would sit there and be like, this is insane. Like, we know that if you numb the skin before you cut it, then even though the brain is asleep, the body does not perceive the pain. And so when they wake up, they don't have that systemic memory of the pain that occurred during surgery. Now, I've been criticized by surgeons recently that were talking about the pain approach. And in their criticisms, they did a whole video on it. One of them was, well, how do we make pain better? And the surgeon said, well, we give these medicines before. They're talking about gabapentin. And they said, and then right at the end of surgery, we inject him with a long-acting medication, and that can last for 7 days. And that's what he's doing. They missed the whole point. They missed that entire section in medical school where you have to numb the patient before you cut them. So when I was watching the video and I was thinking about their criticisms, I was like, wow, they really still don't understand the basic principles of analgesia. They never learned in medical school. And I knew this person, I know them well, like personally, and another surgeon. And I've seen them do the surgery, and I know that they don't use it because I train in the same place they did. So I was like, okay, they're still up to their old tricks. They haven't learned. And this is very important. So, any surgery, breast surgery, face surgery, abdominoplasty, whatever, if you inject the skin before you cut, it's a better outcome in terms of pain for the patient, because even though they're asleep, they're not feeling it. Now, during surgery, after I've finished all that, and you cannot inject that at the same time as the long-acting one, because the long-acting one, it exists in these little fat pockets, okay, which are called liposomes. And it's like liposomal bupivacaine or Marcaine, which lasts for a long time. And if you put lidocaine in at the same time, it will displace the long-acting agent, the bupivacaine. It will not work. So the two will counteract each other. So first you inject that one thing, then I do the surgery. Then once everything's open, after I've elevated the skin flap, I inject right where the nerves come out with that specialized form of basically Exparel, which is this medication that lasts up to 7 days in some patients. And I'll use ultrasound to visualize where I'm injecting, or nowadays I don't need to because I know exactly kind of where the anatomic borders are. And that's essentially like a tap block, which is a block that blocks all the nerves that are coming into the abdomen. And then I also inject the incisional areas. And then at the end of surgery, everything's being closed. I make sure that there's Exparel in other places too, if we've done surgery on the breast or other areas. So this is the approach. Okay. And then at the end, when they wake up, we do other things. When they go to the aftercare facility, a few other medications that kind of fine tune things. But this is the approach. It doesn't sound that complicated, but people aren't doing it. And why don't surgeons do it? Because it takes time, energy, and money. And those are the three things that no surgeon wants to spend, period. Okay. They avoid those at all costs. And I say, hey, in my practice, what would my sister, what my moms want? In my practice in general, my North Star, my mission statement is patient care always. So what are the things I can do to improve patient care? And if it costs me money, it takes me time or energy, fine, so be it. Because I'm not going to get rich doing one tummy tuck. Okay. I'm going to do well as a practice if patients have good outcomes and great results. And I know in my mind that that's what allows me to sleep at night. That's what I think about. Not how do I make another $1 million in my practice? How do I increase my revenue? How do I cut corners to, make my margins better? No, I think about how do I give this patient in front of me the best result? It's not another notch on my belt. I don't say I've done thousands. This is just the next one on Wednesday. No, I think, okay, what am I doing today for this patient? How are we going to make the experience better? And what can I do to invest to make it a better experience? So Exparel is expensive. The time in the operating room is expensive. Okay. And the energy to figure out how to do this takes many years to really figure it out. But I made that investment because that's consistent with my ideology, with my mission statement. And I never cross over that mission statement. So that's how I approach pain control. And that's how it's different. And with that approach, women, their average pain is 0 to 2 out of 10. And I've proven this with a study, 90 patients, consecutive patients published. And this is what I give talks around the country about. This is why they invite me to talk about how do we make the experience better? How do we make perioperative pain control better? So I'm still pushing it. I think that it's still a good idea. I think when patients come in and they tell their surgeon, well, this guy is talking about painless, drainless, like whatever, it makes them uneasy and it makes surgeons afraid because they're thinking, shit, do I have to change what I'm doing? Like, am I going to have to spend $300 a patient on this Exparel medication? I don't want to do that. They'll say they use something called fake Exparel. It's like a different knockoff version of it. They'll do little things to kind of move towards the middle, which is fine. If I'm keeping people on their toes, if I'm scaring other surgeons a little bit, if it's making surgery better for other patients, great. If I was being really mean, I would not give talks. I would not publish papers and show people all my tricks. I would just get online and say, come to me, it's different, and charge $100,000, and just say, look, you want to come to me and get it done, then come to me, or go to these other guys that don't know what they're doing. But I don't do that. I don't gatekeep. I think that's wrong. I think we should look at the specialty and say, how do we make this better for all patients? Not just mine. Not just the patients that are coming to see me. How do we make this experience better for all patients around the country? How do we make it better? So that's my thought process about it. And those are the things that I do in tummy tuck that are different.
My girls, after hearing this, I'm sure they understand and they know now why I chose to have you on the show, because the things that you're talking about are very important to me for them to know when they're looking for their surgeon. What are you looking for? Are you looking... And we talk about this all the time about if you're going to a surgeon, you have to align with how they do things. You have to like the majority of their before and after pictures, but also like them as a human being, because they have to be there for you after surgery. And if you don't get to meet them before, if you don't really get to have a conversation and get to know them, if they don't even get to know you at all, and you don't meet them until the morning of surgery, you guys already know that's not my boat. So after this conversation, a lot of things we talked about so many things. Like you talked about so many things that I know my girls want to go into detail about. Like, for example, how many of my girls listening right now are considering getting a fleur-de-lis because they've been told that's their only option? And it's such a wide range of, how can this one have a tummy tuck and have a great result? And her skin was looser than this one, and she had to have a fleur-de-lis and to get all of it. So it's such a wide range of how it can be done. And I can already tell you that my girls who are listening that are looking for a tummy tuck but have been suggested a fleur-de-lis will be knocking on your door and seeing how you can help them and hopefully avoid that vertical scar.
Yeah. And there are other approaches too. Like, but aside from fleur-de-lis, there's another approach where you can do incisions on the sides, right? So you can do what's called, basically it's called an apron style, but you can remove skin along the side here instead of down the middle, which is a good option in massive weight loss patients if they really don't want to have a scar on the side. But I would just say, if you need a fleur-de-lis because of losing 100 pounds or something like that, then you need a fleur-de-lis. If you have excess skin, it's all about identifying where the skin is and removing it. If I can create tension down the midline and avoid that, then it's nice. You don't need to have that vertical incision. But I would say that I don't know how to estimate what percentage of patients it's eliminated that from in my practice, but I have done fleur-de-lis. I've done maybe one in the last year on a patient who had lost like 140 pounds and still needed to lose more weight, but she wanted to have like an early intervention because her skin was just like rubbing against her clothes, getting caught on her tailgate hitch, all this other stuff. So I would just say, yeah, happy to entertain that discussion with patients and to say like, hey, you should have multiple opinions, multiple surgeons look at you if you're considering a fleur-de-lis, because then you can get a few different kind of concepts and ideas about why it's important in your case. Now, there's one other thing that I should mention, which, you're talking about how you pick a surgeon, but I want to talk about safety, because I think that you should vibe with your surgeon. They should be supportive. You should find the right person. But I also think you should know, how do we define safety, or how does that person define safety in their practice? Because let's face it, this is cosmetic surgery and we're talking about moms. Okay. We're talking about mommies. They got stuff to do. They got families at home. They do not need to run into complications. They do not need to be going to the hospital or potentially dying from a fatal embolus or something like that. So safety is an important concept. And in my practice, I'm going to tell you what that means with regards to abdominoplasty. I'm going to kind of talk a little bit briefly about fat transfer and combined procedures, because I have my own thoughts on that. And I think that needs to be discussed. And that's kind of the 10,000 pound gorilla in the room that a lot of people that have even been on your podcast have avoided having the conversation about. And I think that's unfair. But I'm going to talk first about safety in abdominoplasty. So in abdominoplasty, how do we define safety? In my practice, I say, here's how. There are many different ways that I define it. But the first is using a board certified MD anesthesiologist. Okay. Why? Because that person is in a cosmetic setting. They're not in a hospital with backup. They're in a setting where they're in a situation where they're completely responsible for what happens. It's best if they've been in a hospital, they've done ICU care, they've taken care of cardiac patients, other really sick people, and now they're transitioned to a role where they're doing mostly healthy cosmetic patients. I don't have anything against CRNAs and non-MD people, but I do think that a lot of them that are fresh out, the CRNAs, they're used to an environment where they're being supervised by an MD. Somebody else is there. And that's originally what they were intended for as a specialty, was to provide support in the hospital when they didn't have enough anesthesiologists to kind of do anesthesia. But when we're talking about fully elective cosmetic surgery in an outpatient environment, not in a hospital, I think you should really be considering using a board certified MD anesthesiologist. Now, number two, board certified plastic surgeon by the American Board of Plastic Surgery, not a cosmetic surgeon, not a fake plastic surgeon. Okay. There are fake plastic surgeons. They say, and they do a lot of surgery. Maybe they're good at this point because they've practiced on thousands of people, not gone to residency, but they've done it. So a board certified by the American Board of Plastic Surgery, that's me. Okay. So they look at me and they say, your results look good, meaning you know how to do these types of surgeries, but also your outcomes are safe. You don't have patients dropping dead left and right. Okay. You don't have complaints against you from the medical board for hurting people. And you have ethical practices. You're not out there doing unethical things, because unethical things and behaviors that are not good translate to behaviors in the operating room, like cutting corners or making mistakes or doing deceptive things with your patients that take advantage of them because you are their doctor, right? And they are your patient. So ethical behaviors. So board certification matters because they look at those things and they say, that person satisfies these different things. And even still, some people slide through that probably shouldn't, or that make mistakes afterwards. But I would say if you're in that category, your odds of finding someone who knows what they're doing and our behaviors is high, very high. Now, And I'm sure, there are people outside of that arena that may be qualified, but why didn't they just go to medical school to be a plastic surgeon? Why didn't they just do the hard residency? Why didn't they just take, you know what I mean?
This is such a hot topic because since the initiation of this show, I have advocated completely for my girls to look for board certified plastic surgeons and to really do their research, right?
Why is that important, right? Because people say like, well, this surgeon has performed 10,000 abdominal or breast surgeries and they're an ENT, right? In Los Angeles, there's one guy, right? He's an ENT. He's done tons of breast surgery. Why is it important? Well, fundamentally, what's the underlying principle of medicine? First, do no harm, right? First, do no harm. And a part of it is that surgeons and doctors have to act as a fiduciary, meaning we have to act in your best interest, not our own. Okay. So from the get-go, if you're marketing or the first time the patient considers you, you are lying to them about your qualifications, that is a red flag. That means that everything else that happens from that point could be a lie. Okay. And that's important. And I have seen complications from people that are not plastic surgeons that are doing it. I'm not saying that they're all bad or whatever, but I'm just saying that like, if I from the get-go tell you that I'm a neurosurgeon and I'm not a neurosurgeon, and then I go operate on your spine and you're fine, does that still not bother you that I told you I was a neurosurgeon and I wasn't one? And in what other world in medicine, see, that's a good example, but what other world in medicine would this happen? Are there like, GI doctors out there telling people that they're a facelift surgeon? No, because it just wouldn't make sense. And it's unethical, right? But also that person who's spent their whole life saying, I care about patients, that's why I want to be a doctor, is now all of a sudden lying to people about what they are. Just say you're an ENT. Just say, I do breast surgery. I trained as an ENT, but 20 years ago, I started doing this before that even existed. And I've been doing it for 20 years. And so, yeah, choose me or don't. Right? Like just pick me or don't pick. And then at least you're not like creating a false pretense with your patient. And I think that would be better. And certainly I think that there might be surgeons that are not board certified plastic surgeons that are good at some of these procedures or maybe are good, but I don't think that they're necessarily a good person if from the beginning they're lying to their patient about their qualifications. And we need to be real about that. If you're a patient, you're like, yeah, but I really liked him. He had a beautiful clinic, whatever. And then I looked him up and he wasn't board certified. Like, if that bothers you, then don't have the surgery, because that, and there's a lot of things that can be swept under the rug. Okay. A lot of things. So I think that we need to be real about that. And in medicine, we need to stop like doing things that, we need to like look at patients and say what's in their best interest. And, there's plenty of plastic surgeons that have been trained. There's plenty of plastic surgeons out there. Do we need like all these other people to come in and fill the space of what doesn't exist? No, it's stupid.
I think one important thing that we should talk about is who is telling these people who is telling these surgeons that they can pick up the cannula and start doing liposuction in their office? Nobody. It's the laser and the companies, the reps from these different companies who sell these different machines, who sell these different equipment, who sell these things, who are coming in and training primary care doctors. They're training all of these people on how to do these treatments and giving them the seal of approval. And okay, now you can do it. Here you can market yourself as offering cosmetic treatments. And who's really suffering? The patients.
At the end of the day, companies will only ever exist and support their own bottom line. The companies only exist to further their own profits. But the person who's supposed to be the gatekeeper is the doctor. So if the doctor, if a liposuction guy comes to a general practitioner's office and says, you can do liposuction in your office and you can charge this much money and you'll make cash and it'll help your bottom line. If that person is like, yeah, then that means they're putting profit over patient. Okay. And they have no training. So that's dangerous, right? But if they're saying, this really isn't my scope of practice and why are you here? Then it won't exist. It wouldn't exist. Now, some companies have made that pledge. Sientra only sells implants to board certified plastic surgeons. So if you're looking for a breast augmentation and the surgeon's using a Sientra implant, that means that surgeon's been vetted and they know that. So that in their marketing, they say we only sell board certified and they market board certified. And so if you're getting a breast implant that's in a little orange box that says Sientra, you can trust that that's a well-trained plastic surgeon. And I like that product because of that. And I think most surgeons do. And there's been controversy about it. But at the aesthetic meeting in 2013, Steve Teitelbaum, a well-known breast surgeon, got up in front of the crowd of all the CEOs of all the breast companies. And he said to Allergan and the other, when are you going to stand up and make the same pledge that Sientra made and only sell board certified? The CEO of Allergan at the time, there was like a hush in the room, right? All the CEOs in the front. And the CEO of Allergan at the time stood up and said, well, it's only a small portion of our practice, these non-board certified. And then Teitelbaum said, well, then give it up. If it's like a small percentage, then what does it matter? Just do the right thing for the patients. And what happened? Nothing. They still sell the non-board certified. And they, and so, it didn't matter that the surgeons were trying to get the companies to make the right decisions. They just look at their bottom line and say 2% more, we'll take it. There's money on the table. They're going to take it because they're a corporation. And we know in America that corporations act they're beholden to their shareholders and to their profit margin. And that's it, not to the patients. So keep that in mind. And I think that when you're talking about, getting real about the companies, I think we can all have that discussion. But at the end of the day, it's up to the doctor. And that's why I say if the doctor is marketing themselves inappropriately, then you need to think twice, because that means that they have stepped over that boundary. Now, I want to get back to how we have safe surgery, because we need to be up on this. We can go on a tirade all day about it, but safe surgery. So I just said board certified anesthesiologist, board certified plastic surgeon. Number 3, I only operate in a Quad A certified facility. Quad A is a group that looks at the facility and says, this facility is well maintained, good anesthesia machines, good instruments, low risk of complications, low rates of infections, other issues. And the doctors that are operating here are qualified. Okay. So if you have a facility for surgery that you're going to, you ask, what are the certifications of the facility I'm going to be operated in? If they say Quad A, you're good, you're golden, because it requires even that I have operating room privileges in a hospital within a mile of the facility. So if it's not Quad A, it might as well be their backyard. Like, you don't know what's going on there. If it's not being certified by this certifying body, you might as well be having surgery in a van. I mean, it's that bad in some situations. So we just talked about board certified anesthesia, board certified plastic surgeon, Quad A certified. Now, the last one is, I think, the most interesting one. And I think surgeons will disagree with me, but I'm going to say it anyways. I only operate in a facility where there's at least one more operating room right next door. Why? Because there's another plastic surgeon and another anesthesiologist. Why is that important? Well, if I have a stroke during your case, next door, Paul Nassif or Garth Fisher in the other room, or Galanis in the other room, because I operate in the same surgery center as those guys, they're going to come over and finish your case, and you're going to be okay. I'll be dead, but you'll be fine. Okay. Now, it's not that extreme. It's never like that.
But I understand.
But maybe the nurse can't get an IV here. Another nurse comes in and helps get the IV on the other side. Maybe one of the instruments has an issue. Well, we have 3 ORs. In the place that I operate, it's the same surgery center that's in the TV show Botched. So we have 3 ORs. So we have another device that we use that we can bring in. It's called backup equipment, right? If my anesthesiologist has to go early because of some kind of issue with their kid, there's another anesthesiologist. Or if they're having an issue with what's going on with your equipment or some question, there's a team. Also in the recovery area, the nurses, they've taken care of every VIP in the world. They take care of cosmetic surgery. They know what to look for. They know the issues that can come up. They're not doing a bunch of knee surgeries and then I bring in a facelift. It's not like that. And they know how to look for the things that can be real problems that happen with your surgery, your cosmetic surgery. So that's how you ensure safety, okay, in my mind. Now, the last thing I would say is this. I use Lovenox on every patient. Okay, I'm going to say it again. I use a blood thinning medication on every patient that I do a tummy tuck on. Most surgeons don't. Most surgeons say, we're going to do a Caprini score. We're going to look at your risks of having a DVT or not. And that's going to inform what we're going to do in terms of the medication. And I think that's fine. That's probably safe based off of the data and the literature that's out there. But I use a weight-based dose or calculation of Lovenox, a blood thinning agent, and I give it to the patients for about 5 days after surgery. Because even though it's a very low risk and it's somebody who's healthy and has no other issues, I would rather risk bleeding on the inside or bad bruising on the inside, which are 2 things that I can fix because I'm a surgeon. If you have a hematoma, I can go wash it out and fix it. I'd risk that over having a blood clot in your legs that goes to your lungs. And in my practice, because I use stitches on the inside, my risk of hematoma is very low because there's no place that blood could accumulate if it happened. Okay. So I've seen like one patient where they had a little swelling after surgery that was probably a hematoma, but got resorbed later on, did not need to have to go back to surgery. So I am much more comfortable using Lovenox after surgery. I'm less afraid of bleeding after surgery, again, because I'm a surgeon, than I am of a blood clot. So I use it in 100% of my tummy tuck patients. And I think that that makes it safer because it reduces the risk of the complication that I cannot fix. And when I was young, when I was a resident, I had a patient that had flown in from Nigeria for surgery. We have a screening questionnaire, part of the Caprini guidelines. And they asked, have you ever had a spontaneous abortion? She said, no. She got a blood clot, which was a very severe one. She had to go to the hospital, be treated for it. And afterwards, when I talked to her in the hospital, what were the risk factors? I asked her again, so you never had any spontaneous abortion? She said, I thought you meant like an abortion. She said, no. And I said, miscarriage, have you lost any? Oh, I had 7 miscarriages. Okay. Turns out she had a genetic predisposition for blood clotting. And that's one of the questions we ask to screen for it. Because if you've lost a child, it can be because of the blood clotting within the small vessels that feed the fetus because of a genetic cause. She actually had that. And so I remember that conversation. I remember that she was fine. She did well. But I remember learning through that experience that sometimes people don't remember. Sometimes the questionnaires are flawed. Sometimes there are underlying issues that are communication issues. And why not just use the medication? Why not just use a blood thinning medication and avoid those potential risks? So that's what I do in my practice.
That's one of those things that we talk about in plastic surgery, that it's always a risk. And whenever I haven't talked to you guys much about Make It Pop, bringing on we're doing DVT, PE, predisposition genetic testing. So we know before your surgery, if you have a predisposition for blood clots. And this scenario right here is specifically why we're doing stuff like that, to prevent things like a blood clot after surgery.
Yeah. And I think that the more that we get, the better that we get, towards genetic testing for these kinds of things, the safer surgery will be. And I think that it's a great addition for what you're doing to improve the quality of care of patients. And I applaud that. I think that having a concierge system where you're looking at patients before surgery to identify their risk factors, to help them to lose weight, to help them to quit smoking, to help them change their lifestyle, all these things help improve the outcome, and they are tremendous and wonderful. At the point of surgery, all I can do is screen. All I can do is screen those things out, because no surgeon has enough time in their own practice to really do the counseling and those other things beforehand. Some practices do, the very large practices where they have weight loss supplements.
100 employees.
Yeah, 100 employees. And that may be the right setup. And I can think of at least 3 or 4 in my back of my mind that do those kinds of things. But I think having a company like what you guys are doing that's offering perioperative kind of workup and management is great. And then it gives you a place to have it all standardized, because every surgeon does different things when they do their pre-op workup. For me, I separate what the pre-op workup from my own practice. So I have another doctor who's not incentivized, has no conflict of interest, tell me whether or not surgery is okay on you. And that's good, because then I'm not incentivized to do surgery on you just to make money, right? Like I can separate myself from that decision making, and I can say someone else will tell me if it's safe to have surgery on you. And I think that that's important too. But like I said, so those are the things that we think about when we think about safety and how we improve the quality of outcomes. Because remember, this is mommy makeover. Every patient has kids they need to get home to. We're not taking risks. Now, in that regard, I think we should talk about fat transfer, because there's been a lot of controversy about fat transfer. And in the beginning of the days, it was seen as a very scary procedure. There was a lot of data in the literature that said that it was a very high risk of death. And nowadays, that risk has been proven to be much lower. Initially, they said that it was a risk of 1 in 3,000 for fat transfer to the buttocks. Now it's more like 1 in 20,000, which seems high, but is not super duper high for cosmetic procedures. The risk of death from abdominoplasty is somewhere in that same range because of the risk of DVT and PE. So I do everything in my power to eliminate those issues. But I think when surgeons are combining the two, so if you're doing fat transfer to the butt with tummy tuck, this is a whole nother ball game. Okay. Now women come and say, well, I just want to do this and just add a little bit of fat to my butt. I say, look, that's a much different surgery. Why? Because the recovery is much different. Because to recover from a tummy tuck with a BBL, you got to have a whole contraption at home in your bed. You're going to be not sitting on your butt for 4 weeks, but you're also not going to be getting up very well because of the tummy stuff. This is a whole different deal. And I think that you've probably talked to those patients before and said, look, if you're going to do this, you can do it, but there's a whole strategy. You got to have a game plan. You got to have all the equipment. You got to have the funnel. You got to have the wedge pillow. You got to have all that stuff. Otherwise, you will be miserable and your outcome will not be good because
you won't sleep. You won't sleep. You
for like
won't
4
sleep.
weeks.
And
It'll ruin
that's
your
it.
life. It'll ruin your life. Now, what I look at it that's why in my practice, if patients want that, I usually incentivize them in this way. I say, look, you can do both at the same time, but we're going to have a discussion about safety. And I think it's less safe. And I think that there is a much higher risk. Why? Because you're combining the risks of two risky things. And no one's done that study yet. No one's shown that study yet to say, what are the risks of tummy and fat transfer? And I was at the national meeting in Miami 3 years ago. They had a panel, Simeon Wall, all these famous surgeons were up top. And I talked to Simeon after and said, we should really do a panel on combining tummy tuck with fat transfer to the butt. What are the risks? Because they were doing all these panels on fat transfer to the butt where they were saying, no, it's risky. It's risky. No, it's not. All this argument. And I'm like, okay, that alone may have controversy. What about combining it with another huge surgery that increases fluid losses, adds on liposuction, creates more time in the operating room, and increases your risk of a DVT? There's some real risk. Right. There should be a conversation. There needs to be some kind of standardized safety protocol, some kind of conversation about that. Because in Florida, you can't do more than 3 now and you got to use ultrasound. But in California, you could do more than 3 still. But no one's talking about doing it with a tummy tuck, right? So what are the added risks? So I tell my patients, we don't know what those risks are and they're going to be high. So if you want to do a tummy tuck and a BBL, I'm happy to do the tummy tuck first. We'll stage it. Yeah, and most patients, 40% of them at that point are like, I'm good. My tummy looks great. My butt looks even better because my waist is more narrow. And you did all the lipo that you do during a BBL without actually adding it to the butt. And then I say, come back in a second stage and I'll do final mile liposuction. I'll do additional lipo. I'll take another 3 to 5 liters. Your body will be insanely different and we'll use that fat to transfer to the butt. And that reduces the risk of the 2 procedures at once. Plus it makes your recovery better. And the recovery from a BBL is easier than the recovery from the tummy tuck. So if you've already done the tummy tuck, you've taken the plunge, you've removed all the loose skin, I can go back in a second stage and really refine that result in a beautiful way and deal with any other issues at that time, like a bad scar, a belly button revision, whatever needs to be done. So I would much rather incentivize that. So I make it the same if they do that as if they did the 2 together in my practice financially. So they can say, okay, I'll add that procedure on without thinking like, oh, but it's going to save me money. Now, downtime is different. Time is more valuable, of course. Having to go 2 surgeries is harder than go through 1. But I want to alleviate some of that stress so that they're not thinking with their wallet. They're thinking with their mind and their heart. What are the risk factors? Does this make sense? So I think that's another important kind of conversation. And that doesn't happen. And they say, oh, yeah, tummy tuck, BBL, no big deal. We'll just do it. Surgeons aren't talking about the real risks. They're putting that a little bit to the side. And they're saying, well, we know we can get a great body transformation if we do those 2 things. And I know plenty of surgeons that do both all the time. I don't think it's an unsafe procedure, but I do think there needs to be a conversation about safety and what the real risks are of combining those 2 procedures. So,
right.
I think that is probably one of the topics that people don't want to talk about. Now, there's a few other things that I would say you can combine, like so in my training, I've done a lot of different, training and different kind of background in liposculpture. And I actually taught the course or helped teach the course in Beverly Hills with Hoyos. It was the first course in the United States in California for body contouring, the TD body course. But
go into detail about that. So spill the tea.
So, the tea is that there are different ways to do liposuction. And in the United States for a long time, just like with tummy tuck without a drain, people just say, just stick the cannula in there and take out the fat, right? How complicated can it be? The reality is I think liposuction is a surgery that's done very poorly by most surgeons and in the United States. And I think that liposuction is actually one of the most complicated surgeries we can do. Anytime a surgeon says, oh, that's an easy surgery, like breast augmentation, that's not correct, because every surgery, in my mind, every surgery I perform is difficult and can be wrong. It can be done wrong. Any surgery can be done. Most surgeries cannot be done well. And I think 90% of what we see in aesthetic space is not done well. So how do we avoid that? Well, or what are the secrets of liposuction? What are the key things that we need to be doing? Well, there's new approaches that involve the use of high definition approaches where we're basically before surgery mapping out your anatomy on your body. And then during surgery, using technology that's designed to improve the quality of those outcomes. It doesn't have to be Vaser. Vaser is one approach that helps to break up the fat, make it softer, make it more like butter when you're putting the cannula through. It can be high def lipo with just power assisted liposuction done in the right way in the right places. But the whole point is to deepen the inscription points, to show the line down the middle, the lines down the sides, to hollow out the areas that are lateral. And this is something that Hoyos has really championed. He's a Colombian surgeon, and it's big in Brazil and Colombia and Central and South America, but also in Europe in certain areas. And he teaches a course called TD Definer, or basically Total Definer, which is a body course. There are other body courses in Central and South America that help to educate surgeons from all over the world. But he wanted to come to California to do the first real course in Beverly Hills. And we did that a couple of years ago. And I was one of the assistant faculty. So I helped to kind of educate and to show other surgeons who come to see that, and actually performed surgery. We did live surgery at that event and showed different techniques. But I would just say that, going to somebody who's had that extra bit of training, who understands those concepts, can get you a much better result, because liposuction, like I said, is not a simple surgery, and using those complex approaches makes it better. And it's not just technology, because you can add on Renuvion or Body Tight. Any surgeon can do that to improve the tightness of the skin. They can add on Vaser to make it easier. But if they're not trained with the concept of identifying and preserving the anatomy and improving it, then you're not going to get as good of a looking result. And if they're not trained on the most up-to-date approaches, then their approach to how they do the surgery is a bit flawed. I could really go into a lot of detail, but it would take hours to explain how we get the right thickness of the skin between the belly button and the pubic area versus what's above, a gradient, right? So you want to have a gradient of fat, and how you change those dynamics. But that's not something that I actively push hard in my practice, because there are things that I like. You can only advertise and market so much. I do a fair amount of high def lipo, but in my practice, I say, who's the ideal patient for me? Who do I resonate with, and what do they need? And it just so happens it's like 35 to 65-year-old women. I'm not doing a lot of primary rhinoplasty, primary breast augmentation, or high def. I mean, I do those things, but I don't market them, because that's a commodity market that's different. I know that grandma loves me, mom loves me, and I'm perfectly comfortable operating on all those patients, and, let everyone else take their other kind of piece of the pie. I do a lot of primary breast aug, but it's small volume, natural result. And those women kind of seek me out. And I think that's fine, because in my heart, I kind of think I want patients that come to me that want to look better, not different. And so I seek out patients who want to recognize the person they see in the mirror, who want to feel comfortable in their body again, want to have functional improvements after having had kids, get their body back, have had their 4 breast surgeries, and they need breast rehabilitation. Take out the implants, do a lift, do a fat transfer, or reduce the implant size and recreate a natural, pretty breast shape. Restore them to breast beauty, take them away from whatever this was and make something different. So in my practice, that's what I seek out, because it just jives with my mantra and with kind of what my desires are in medicine, to help people. And that's why I kind of market more towards that sort of thing.
I love it. I think you've done a really wonderful job carving out your space and your specialty and what you love to do. And the women who come to you, they always talk so nicely about how they experience your office and their procedures and their recovery. I've heard nothing but wonderful things from your patients. So I'm so happy I was able to have you on the show today. We talked about so many things. Like we covered.
We didn't even get to cover any of the face stuff, though.
We didn't even get to do anything.
Technique and the face, deep plane facelift, but we'll get there at some other point.
We'll have to bring you back on. We'll just have to bring you back on and do a part 2.
Yeah, I think that it's rare. That's another kind of concept that I think is really important, even though we didn't get a chance to talk about any of the facial surgery that I do. It's extremely rare that you see a surgeon who operates on the face and the body, and they have to be well trained to do both. But in my practice, in my experience, I go and give talks in the meetings on facelift. I get invited to the facial plastics meetings and to the other meetings that are not just body meetings, to go on the podium and to talk about these things. And it's because I link the two. So we talked about it briefly, but the concepts of anatomy and restoring what's on the inside and changing that, making it are linked. So I take the same concepts that we've just talked about with regards to abdominoplasty, high def lipo, and mimicking the natural shapes. I apply the same concepts in the face. And I think that that's why it works. But I would say that would be an interesting conversation, because I think that most patients seek out somebody who's a specialist on the one thing that they want. And maybe that's because they're marketing it or that's what they're really good at. But I'm a rare person who does face and body. And I take that lead from other surgeons like Garth Fisher, other people that I've seen, that I've been around that do both and can do it well. So at a later appointment or later conversation, we can discuss those things. But I'm glad that I had a chance to talk a little bit about drainless and kind of the approaches that are there. hopefully to dispel rumors, hopefully to give you a little bit more kind of confidence in the ideas behind what we can do to make surgery safer, and a little bit more awareness about what you need to think about going into surgery and picking your surgeon. I'm not trying to create fear. I'm not trying to, scare people from having surgery. I'm just trying to say, what is our responsibility as a physician? What's our job as a surgeon to make your experience safe and comfortable? And these are the things that I do in my practice, right? But I'm sure there are other practices that do these things well. But these are things I do in my practice to ensure that safety.
Yeah, I love it. So if our girls want to come find you, how can they find you?
Well, I think Instagram is a great place to look at before and afters and to see more videos of what I do. So Dr. Gould Plastic Surgery is the Instagram, but I also have a YouTube channel that has very long videos that describe different procedures. And those kind of give you everything start to finish, including the recovery timeline and all of that. So on YouTube, it's Dr. Gould Plastic Surgery. And then on TikTok, I have a much more kind of viral following. That's like a lot more followers there, but it's Dr. Gould with the spelled out DocTorGould. And on TikTok, it's more education. So it's a lot of videos of me talking about procedures and controversies in plastic surgery, because you really can't show as many before and afters on TikTok, which you all know quite well. So you can get different flavors of me in each of those different environments, but they're all pretty consistent. And then the website, of course, is drgouldplasticsurgery.com. If you go there, it's got information, including contact from my staff. You can email me, Dr. Gould at drgouldplasticsurgery.com, or my coordinator, care at drgouldplasticsurgery.com for more of that information. But all that will funnel you into kind of the concepts that I provide, and I'll show you more results and kind of give you more flavor. Whenever you're investigating a surgeon, you should look at all of those things on that surgeon has, and look at reviews. I mean, I have Google reviews, Yelp reviews, RealSelf. RealSelf is great because their actual patients have been vetted. So you should look at all those things, and they should be consistent. They should all be pretty similar. The results should be something, like you said, that you like. But those are the places where you can find me and what I do. Or just come to my office, 120 Spalding, right at the tip of the spear in Beverly Hills, the same building as Paul Nassif, Garth Fish. It's like one of the big buildings there in BH.
Wonderful. I'm so happy I had you on. Thank you so much for sharing with us all of this information and teaching our audience what to look for and all about drainless tummy tucks. Let me think. Have I been converted? Maybe I have.
Maybe not fully converted, but at least you have a different perspective on it.
And I do.
Think that, my goal is to make patient care better, not just for my patients. I'm not gatekeeping this stuff to try and drive my own practice. I don't talk down on other surgeons and their practices. All I'm trying to do is say, how do we make this better for all patients? How do we improve outcomes, downtime, pain, recovery? And that's like I said, that's my North Star. That's what drives me. So, I think when you look at it and you think about what I'm doing in the drainless approach, it's really satisfying all those kind of things. And certainly it does set me aside, but it's not the one thing that I use to market. It's like look at the before and afters too, right? Look at what we do in the practice. So I hope that I've added, at least shown some light on what I'm thinking, shown you that I don't think that this is a crazy approach, that I think that it's well-founded, it's scientifically based. I come at it with the right approach, and that maybe that gives you a chance to think more about it, and to think about what other surgeons are doing in their tummy tucks, and to say why, what's their mindset? Why are they coming at me with this new approach? And does it make sense?
Wonderful. Thank you so much, Dr. Gould. I will have you back and we'll talk all about face the next one. But till then, I will see you guys next week.
Wonderful. Thanks for your time, Mavi.
Bye.
If you enjoyed this episode, please go on Apple, write me a review. It's the best way for other women who are just like you, who need help, who are looking for information, valuable information on the internet. This is how they're going to find it. So go on Apple, give me a 5-star review if you love this podcast. If you want to support the podcast, the best way to support the podcast is through the website. If you need help through your journey, if you need help finding a surgeon, if you want to join the membership, if you're looking for Bruise Juice, you guys don't sleep on Bruise Juice. Y'all know I have my Bruise Juice 30 coupon code for y'all to use if you're having a BBL, if you're having liposuction, if you're having a tummy tuck, if you need to be using Bruise Juice all over your body. Stop using those other brands that are not tailored for your post-op recovery. Bruise Juice is formulated for your recovery. It's amazing. It nourishes your skin. It helps your fat transfer live. Don't sleep on Bruise Juice. Bruise Juice 30 is the code.
And don't forget, new episodes every Monday. I'll see you then.